I'm going to bring in Deputy Brid Smith, and we're going to give 5 minutes to each of our non-members. So if you can be concise in your questions. Thank you.
I have a good few questions, so I'll ask them quite quickly, and I'll ask them in a row, if that's all right. The first thing, I want to thank you for your submission, but I also want to thank Professor Grania Flannelly for hers. It's a very informative submission just on how the whole system works. It's very well thought out and delivered. But on the page where she talks about the 28th of April last year, I think this is a really important piece, because her advice, I'll just read out headlines of her advice, to the department not to proceed with offering a second test, where that laboratories would not have sufficient capacity, open access for repeat testing would be difficult to plan and deliver, colposcopy services would not have sufficient capacity, and it would fundamentally undermine the screening programme. And all of that is very prophetic, because that's exactly what has happened when we've got 80,000 tests in backlog with a 33-week waiting period. And the task to you guys is absolutely enormous. I just want to ask you, was Dr Flannelly a big loss to you? It seems to me that she must have been a huge loss to the service, given the struggle that you have to recruit experts in this field. I also want to ask you, do you think that her advice to the department has resulted, or will result, when this becomes more and more exposed, in a loss of confidence in the department, whomever is responsible, whether it's the CMO and or the Minister himself, for rejecting that advice and putting us into the position we're in now? The other thing I want to ask you about is the record you have of sourcing labs to help you get through this mess. Have you looked to Northern Ireland? They have 4 labs, and I believe they have capacity, and maybe you could address what the result is in Northern Ireland. And you mention all the time challenges with your other partner, having said that you've made progress with Coombe and Quest. I'm assuming that's MedLab. Could you spell out a little bit for us, even I don't want to take up your whole day, but what those challenges may be, the headline issues around those challenges? In your submission under supports to women and their families, you say in the provision of access to their records, you support them in the provision of access to their records and ensuring that their slides, where they're required for legal review, that they can get them. So there's 118 of the 125 slides that have been requested have been dealt with an average waiting time of 27.5 days. This is under the headline of support for families. So there's 7 still in progress. Are there legal proceedings pending in those 7 cases? And is there one particular lab involved, or are there multiple labs involved? Can you answer me that? And under the independent review, you say in recent weeks the labs have commenced the transfer of slides. So I'm quite passionate about this, because last June we were told that the Royal College of Gynaecologists estimated it would take 6 months to conclude, and I understood it meant to conclude their examination on the independent review. But now it looks like that you're being told that the review it'll take time to review the transfer of slides. So has the Royal College of Gynaecologists review taken all this period just to get the slides transferred to them, or is the review due to be completed? And did at any stage the 221 group ask to be removed from that review and dealt with separately, and why would they have done so? And very lastly, information in relation to requests that I have repeatedly made for where what labs the false negatives came from. So I was told repeatedly in PQs and at meetings like this by the Minister and his department that would be dealt with under this RCOG review, that was how it was going to be dealt with, and until that review is conducted, I can't have that information. In a separate PQ, I was told that an expert was being appointed to look at that and to get me that information. All this time later, the information is still not forthcoming. And I want to conclude my query by saying this, that this goes back 10 years ago. The decision to outsource the service was a mortal sin because it has led to the deaths of women. It has led to the mess that we're in with Cervical Check. And that is what I am trying to get somebody to say, to admit. What scares me now is that the only step forward that we seem to be making in HPV testing is to again outsource. And this, I think, is really, really worrying, that the outsourcing of women's health is continuing, the plans to continue to outsource it, when we know that 10 years ago the decision to outsource has led to a complete mess. I'm delighted to hear you're reinventing the CUM as a public clinical service. I think that's absolutely the way to go, because I think at the time university courses, etc., were shut down because of the decision to outsource, and we lost the capacity to do our own screening in terms of clinical experts that can examine these things. And I'm delighted to hear that they were reinstated.
Thank you, Deputy.
But would you agree with me that outsourcing has been a disaster? Are you concerned that we are now being forced to outsource the HPV test?
Thank you, Deputy. You got all your questions in there. So if you, Mr McCallum, if you could
with my colleagues will try and address them. So maybe I'll just take one or two of the ones first that can answer quickest. So in terms of the RCOG will produce the overall report in relation to the laboratories, not just in terms of the 221 women that were initially affected and their families, but also in terms of all of the cervical cases of people who consented, of which there's over 1,000. On the report that the Deputy refers to then, we have completed a report which is simply to give a profile of the laboratories with an explanation where we got someone from out of state to do that. We're meeting with the patients because it's about the 221, so we've always said the first group we will meet to go through any of that information is with the patients, and we're meeting them in the next couple of weeks, and once they're happy with it, we'll release the report, Deputy. So that bit of work is done, but as I say, the patient representatives are our first port of call on that. In terms of the ORCOG review and the 221 group, I'm not aware of a request to be removed. I'm not saying that didn't come, it may well have. The RCOG is an independent process. Our role is really just to try and support it. Now, we have a very significant team working on it because we had to manage the consent process, the information line, and a whole range of areas. But the RCOG is an independent review, and we have a weekly call with them. There are a number of people who've consented within the 221. I'm aware of that. I couldn't give you the exact numbers, but there certainly are people who've consented to participate in the review. There were around 1,800 people, I don't know the exact figures here today, but who had invasive cervical cancer, and of those, about over 1,000 have consented to participate in the review. And those slides are with the RCOG and going to the RCOG, where there's about 1,000 slides gone. And I think in total, I haven't the number of women, but there are more slides obviously than women. And there's about 600 scheduled to go over the next 3 to 4 weeks, which will complete the slide transfer.
But that's not the review. That's not the completion of the review. It's just the slides going.
Yeah, they have started that process. So once we started sending slides, essentially they've been starting their process of reviewing those slides, and they're also reviewing the colposcopy records and the cancer records. So it's a very comprehensive review. And
do you have a date of when you expect it to be completed?
Well, it's the RCOG themselves that would indicate the date, but the indications I have, and it's just the indications from them, a period of around 6 months. That's the indications. But that would be for the RCOG to confirm the date, and that we're just there to support them.
But with all due respect to you and the RCOG, we were told that last June, 6 months.
I can only say what the RCOG, you know, the information, that's their expectation around it is that sort of period. In terms of sourcing labs, on the third lab, we have identified some capacity through that, and we've been working with them over the last number of weeks to try and go through all of the capacity elements, the operational elements and the legal elements of that. We're at a very critical stage over these couple of weeks, so I'm just being cautious in terms of what we say, but we have identified capacity that will help. We have, as I said earlier, 2 of the labs have made significant improvements, and they have identified further capacity as well. We will, as I mentioned earlier to Deputy O'Reilly, be doing quality assurance visits. There's a new pre-inspection process that Dr. Doherty referred to earlier that the laboratory must go through as part of the quality assurance, and there will be on-site visits against a quality assurance standard, an updated quality assurance standard, and those are being scheduled rapidly in order to ensure that we get to a point where we can secure that capacity. It is a real challenge, I'm not underestimating it globally, to try and find laboratories where people are moving to HPV. To get cytology is really difficult, and that's the other reason we want to move to HPV as quickly as possible. In terms of the outsourcing, I mean, what I would say there is we have recognised that we need to invest in the public system, and we're doing that through the CUM. It is going to take a bit of time. It isn't just the construction. That's an important element, and designs have been pulled together, and that's been fast-tracked as best we can. and we've had good support from our own estates people in doing that. But it's also ensuring that we develop the medical manpower, and that's quite complex because, as I say, it's such a highly specialised area. There never were many of these people in the country, and we've activated and talked to some people who've been involved in the specialty before about trying to re-engage them. And we're looking at trying to grow and develop the consultant workforce, and we have started to pull together some plans around that. Recruiting screeners is also very challenging in terms of the COOM, and the COOM have really, I have to acknowledge the support they've given us, their board and the hospital, in trying to support the programme through this difficult period. So we're committed to that, and we're committed to getting that up as quickly as we can. There is a reality that we will still need a partner for the next number of years, for a significant number of years. It will take time. Our aim would be to get the COOM up to around 50% within around a 2-year period, but we will need a partner, so we need to try and ensure that we have a partner. And there is a very limited pool of companies that do this work, so we have to be very careful in how we manage our communications, how we manage our engagement, and the procurement strategy we've picked for HPV allows us to have dialogue with the market, because there's a real risk otherwise that we could be left without a partner. So we have to make sure that we can secure a partner. And we had a pre-market engagement before Christmas, which was very successful. We had a good interest, but it is a very small number of providers that offer this type of service. So we have to try and make sure that we bring someone with us in order to ensure we get through the HPV screening.
Did you check Northern Ireland for the last?
Sorry, yeah. So we met Northern Ireland, myself and Lorraine. Lorraine was actually in a rolled role in Northern Ireland and kindly joined us before transitioning. We met with Public Health Northern Ireland. They are currently in a process themselves of moving from 4 laboratories to 1. The timing for them at the moment would be a challenge. There is no significant capacity there that would address from that meeting our requirements here in terms of what we need. And we've also had discussions with other parts of the UK and with Scotland.
Thank you very much.
Sorry, no, there's just a couple of questions that I want answered. When I asked you about Professor Flannery, was she lost to you? And is it unusual for the department to reject advice from somebody as expertise as her? So
the loss of someone, in fairness to Gráinne Flannery, she has done huge work in cervical screening over the years, and you have to acknowledge that. She started the programme and did phenomenal work. Clearly, coming into a programme without a clinical director, and Dr. Peter McKenna kindly stepped in, even with his other roles for the intervening period, and Dr. Doherty has now moved into the role. So losing a key clinical role at any point in time, of course, it has an impact. In relation to the other point, we discussed it earlier. I don't think there's anything we can add in relation to the history and the timing of it. We've talked about the context, I guess, for the decision at the time. Personally, I wasn't there to judge that. I articulated earlier how we work with the department in terms of the advice we would give. If it's policy matters, it's a matter for the department. If it's operational matters, you know, those are things that would be.
Is it unusual for the department to reject advice from somebody as professional as Dr. Flannery?
Well, we don't know that they did, in the sense of how that all operated. I think we've been through this a number of times today. We're not in a position where we can add to that. We can explain the context at the time, in terms of the difficult circumstances that were faced by GPs, by women. And just maybe just to illustrate it, I mean, our cervical helpline would typically have had hundreds of calls, you know, a couple of hundred calls in a week. We jumped to thousands at that time, which created its own challenges, you may recall, in terms of responding to women. So there was a huge public pressure that was there.
Sorry, Ms. Smith.
There's one question you didn't answer. That's all.
Okay, sorry, Deputy.
On the supports to women and their family in your submission, you talk about 118 of the 125 slides, and I asked you about the outstanding 7.
Yeah, so there are always a small number that are obviously work in progress with the laboratories, and the laboratories deal directly with any person's solicitor in that. I couldn't answer, Deputy, if there's one that's an active case, but I will confirm that for you and come back to you if that's okay. Are they cases subject to legal proceedings, is what was my question? Well, they may be, sorry. So basically the process is, if a woman will have asked a solicitor typically to take on the role for them of securing their slides. So it's rare that a woman themselves will come directly. It does happen, but generally they will do that through a solicitor. So whether the woman then chooses, you know, in terms of taking legal proceedings, will be a matter for them. We don't concern ourselves with that. We simply look to try and get the slides to their solicitor as quickly as possible. But if your question is, are there any of the ones that are outstanding where there's a delay, say for example in the case, I'm not aware of it. I'm sure it would have been highlighted, but I will double check that if that's okay and revert back to you.
Okay, thank you.
Mr. McCallie.
To ask is, in your report, under progress report on internal cancer audits, You talk about how the expert group is looking at processes that should work in the future. But it is not the case that after the Vicky Phelan case last April, the internal audit was shut down, and that since then there's about 250 to 300 women who've been diagnosed with cervical cancer across the country who are excluded from the 221 group. In other words, they haven't had an audit done, they haven't got access to the particular care package that the 221 group have done, and yet it's likely that they have a smear history because the smear test programme was in operation for about 11 years. But was the audit shut down to keep that figure at the 221 and to stop it growing? And are you not deliberately denying women of access to, the full healthcare package, to audit that would then allow them look at their history in the context of what happened to others, and that there could be, given the law of averages, there could be 50 to 60 women out there who are dying or suffering from cervical cancer at the very least, who might fall into the 221 category but are being shut out because you closed the audit and did not replace it. And really, to be honest, nobody ever said there was a problem with your audit. And the way you carried out the audit seemed to be perfectly fine. The problem was that you didn't tell the patients about the results, and that was the problem. So you shut down the audit, you're looking at a new type of audit, but in the meantime you have this whole cohort who are being excluded. Would you acknowledge that that's the case?
Thank you, Deputy Smith.
Ask Dr. Henry then to speak just on the first piece in terms of women who had cancer who were outside the original audit that's been addressed through the Royal College review. So in other words, if there's an outcome there, then that will determine whether or what needs to be put in place for those people.
And the Royal College review has been delayed and delayed and delayed.
I appreciate that, but I'm just to identify where they are. In terms of, I might ask Dr. Henry just to talk about the interval cancer audit group and why that's needed. And Dr. Scally did actually make a recommendation that there were issues with the audit. Just to maybe ask Dr. Henry to expand on that.
Deputy Smith, I think. I can't remember the exact quote that Dr. Scally had, but he did characterise this audit as flawed in terms of its design and implementation. It's easy to forget how, as you point out here, the failure it wasn't just the failure of disclosure, but it was the design and implementation of the audit that was found fault at the time. And it was also incomplete in that it didn't include patients who were characterised as having cancer on the NCRI. So if we look at quality assurance, and there's been much discussion this morning at other fora of quality assurance, audit of interval cancers is but one component of quality assurance. Quality assurance of any programme looks at the whole scope, the whole range, the whole pathway of care, from the credentials at the labs to the smear taking, to the communication with women, to the whole range. And the one other component of this is looking at interval cancers, and to learn from this. And we're aware, not just through this screening programme, there are other screening programmes, that there's very little evidence internationally on how they should deal with open disclosure of interval cancers. And so what we undertook to do after the Scally report came out was to look at all 3 cancer programmes and design a look at interval cancers in those screening programmes, bearing in mind that we all want screening to flourish and to thrive, and to women to have confidence in the programmes and to partake in them. And based on the best international advice and the best expert advice we have here in Ireland, to make recommendations as to how we should deal with interval cancers, be they in breast, in bowel, or in cervical cancer. And this work we're undergoing now. It's led by Professor Susan O'Reilly, who previously headed the NCCP, and we're hopeful we'll have an outcome from that in the summer.
Well, yes, for the women who are excluded from an audit and who are likely to have had a screening history that should be examined. And what is the answer to them? They're being excluded from a group that has access to a certain healthcare package that is, in the case of Vicky Phelan in particular, is proving to be absolutely excellent. And I think it's disgraceful that they're being excluded from that. If they've been diagnosed, they haven't had the audit, they should be included into it. But I just want to take up what you said there about it being difficult to know how to inform women or patients of results. There is a step-by-step guide available on the NHS website, I'm told. I haven't looked at it, but I believe it's very good and very considerable. So what is the problem, therefore, other than you shut down the audit in order to exclude others, to stop that number growing. 2 to 1 remains 2 to 1. It doesn't become 421 or 491, whatever. I think that's pretty disgraceful if that's the truth, and that's what it's becoming more and more look like, particularly when you report that your audit proceedings, you're sitting down with committees and with groups to find out what's the best type of audit. There is no proper audit there to look back at their screening history.
My understanding, Deputy, is first with regard to the provisions given to the 2-1 group, that was in recognition of the fact that there was failure of open disclosure to those women off the audit. But to go back on my point is the audit was paused not in any sense, as my understanding was, not in any sense to deny anybody else access to those supports, but because there were faults in its design and implementation and it was incomplete. That's why it was paused. And you referencing
for a whole year.
If I could just finish, Deputy, on the point of England and Wales, I visited Public Health England, and you're absolutely correct. There's been guidance in place since 2016 in Public Health England with regard to communication of interval cancers. But other healthcare systems, Germany, France, Australia, looking at other cancer programmes, do not have and have no active policy on open disclosure in interval cancers because they're population screening programmes. So there's a variation of opinion on this issue internationally, and what we want to do here in Ireland is design something which will enjoy public confidence and will also allow the screening programmes to thrive.
Well, I contend that you're doing a big disservice to a cohort of women who are suffering at the moment by not having an audit in place that will sufficiently address their concerns about their screening history. And that if you don't have that in place, the only thing I can conclude from it is that you don't want that figure to grow. And this is more lack of open disclosure, if that's the case.
Well, in this, what I described, Deputy, in us looking at interval cancers, we've actively included patient representation in that group, and they're contributing to that work. So, and those patients understand, as we do and as you do, the importance of public confidence in screening programmes. And that involves public participation and quality assurance of the whole range of screening activity.
I understand that, but you say in your report that you have independently chaired, made up of clinicians, patient reps, public health professionals, medical bodies, and it has met 4 times to date. This is a whole year ago, and there's 250 to 300 women diagnosed with cervical cancer since. If I was one of them, I'd be really feeling let down by the state, by the system, by you, by everybody, that there isn't an audit available of my screening history in this context. 4 meetings in a year to decide what to replace that with. It's not acceptable.
Deputy, just say those groups are only created on the back of Dr. Scannell's report, so they're only in place for, so they're deliberately set up.
It's still not acceptable.
But we must make sure, Deputy, we get it right. Like we've made, the previous process.
But you can't reinvent the wheel. You keep quoting other systems, other countries, Australia. Look at their models and adopt one of them.
That's what we're doing.
Or at least reopen the audit you had, because it served some purpose.
But, Deputy, it was flawed, and Dr. Scally was very clear.
The open disclosure was the flaw. The lack of open disclosure was the flaw, not the audit itself.
Yeah, the Dept.
Smith.
Dr. Scally did say that, but yeah, sorry.
Could I ask a question? In relation to audit is